Good evening and welcome. I have the pleasure to introduce my co-speaker, Mr. Jonathan Glass, who is a consultant urologist at St. Gaius and Thomas's Hospital. He is also a British Association of Urological Surgeons representative on College Council. He is editor-in-chief for the College Bulletin and also prolific writer for BMJ blogs. May I therefore now present Mr. Glass to start the presentation, please.
Right, hi Pragnesh, and good evening everybody. Virtual consultation. So let's go straight to the first slide. And Yuval Noah Harari, that fantastic writer of 3 books, Sapiens, Homo Deus, and 21 Lessons for the 21st Century, has identified that we're living in a different era, that humankind has technology expanding and it's becoming part of us. We never walk along the street now without using our mobile phones. And it's been identified that this technology is coming into a vital part of healthcare. And clearly we're having this presentation because virtual consultations have become part of us because of COVID. But it's a direction that was happening anyway. Online shopping was expanding, Zoom conferencing was going to happen. And what COVID has done has just precipitated these events to bring them forward much sooner than they might otherwise have occurred. Next slide. So what we're going to go through is what's the same and what's different between a virtual consultation and a normal consultation, the pros and cons of the teleconsult, how we get the consultation right, preventing being what I refer to as a heart sync doctor, and then when it's right to do a teleconsult and when it's not. And then later on, Pragnesh will go through some of this again and give us some other thoughts. Next slide. And I'm not so keen on the term virtual consultation. I prefer the term teleconsultation because it's not virtual. When you think of virtual technology, you're imagining an electronic sphere. But actually, this is a real consultation. There's a real doctor and a real patient at each end of the wire. It's a vital link for the patient, and in this era where many patients are really feeling very isolated. I have been amazed how many patients I've phoned up and they're just delighted to have a conversation with another human being, and the fact that it's a consultant they know has really enhanced their day, and they've been waiting by the phone for this moment. Clearly, with teleconsultations, there's the possibility of national and international consulting, and the future is clearly going to be a mixed economy of telephone consultations, video conferencing, and hopefully, as soon as we can get back into it, face-to-face consultations. Next slide. I have referenced just a couple of papers which are nice overviews of teleconferencing, and the driver for teleconferencing prior to COVID has come from different spheres. In the fee-based systems, it's based on productivity and billing and administrative considerations. But in systems like ours and the National Health Service, which are free at the point of care, the idea with virtual consultations that they allow universal access, independent of geography, and more equitable access to innovative care, but do so in the context where there's been concern about clinical and data security. There isn't any evidence that teleconsulting actually reduces the workload in primary care, and it clearly favors the population whose language in the native language of the country is good. It's more difficult for those who are less able in the native language to access teleconferencing. There's evidence to suggest it's less appropriate for certain conditions, such as drug dependency, terminal illness in the frail and elderly, and those with learning difficulties and complex needs. Next slide. Tricia Greenhalgh in the BMJ has written that teleconsultations tend to be shorter. They tend to be more linear consultations, and it's more difficult for both the consultant and for the patient to go off on a tangent, and that may be an important something that's important that we're missing from a teleconsultation. It's clear that some of the nuance of the consultation can be missed when you're not seeing the patient directly. And so it's quite clear that in some consultations, the doctor needs to be more explicit to the patient about what they mean about various issues, whereas at other times, with face-to-face consultations, you interpret what the patient is interpreting, and therefore you may not have to be quite so explicit in some aspects of the consultation. It's been shown that teleconsultations clearly work best when the doctor is already known to the patient and where you're picking up on a relationship that's already well established. Next slide. But there clearly are, and so just a couple more clicks, please, I think. And it's clear that there are pros and cons of teleconsultations. And these are two word clouds, which I attribute it to Miss Archie Fernando, one of my colleagues at Guy's and St. Thomas's. And there is a link which you can copy. Unfortunately, you're going to need a friendly urologist to take you to that link because it's only accessible on the BAUS website. But if you find a friendly urologist, they can take you to Miss Fernando's talk. And she's highlighted that clearly there are some pros of teleconsulting. The patient doesn't have to spend the money to get to the hospital. There's easy access. It tends to be quite efficient and patient-centered. But we do lose some of the important aspects of what the traditional consultation. We've lost our visual clues. We can't examine the patient. And that can, we think, lead to substandard consultations and mistakes and a non-holistic approach. And for someone where you're interested in the whole patient, it can be difficult to engage with the whole patient, and the conversation tends to be focused on the issue to speak to the patient about in a fairly narrow and linear way. Keep next slide. There are some aspects of the consultation which are important in the face-to-face consultation, but are just as important in the virtual teleconsultation. And these are things I've written about in the BMJ previously. Know the patient. You can't be looking at the patient's notes whilst they're on the phone to you. You've got to make sure you understand who they are, check any recent communications that they've had. One of my particular bugbears, know how to pronounce the patient's name correctly, and look on the notes or in the computer if the next of kin are named, because when you phone them up, of course, it may be that you end up speaking to the next of kin, and it's nice if you can actually name them. You clearly need to identify whether a translator is going to be necessary, and again, identify whether you've met them or spoken to the patient before. That can be difficult in the context of a long list of patients to call, but clearly it's vital that you don't start off a conversation as if you've never met them before when you've seen the patient previously. And be realistic about the timing. We found that patients may want a precise time when they're going to be contacted, but actually they may not be so realistic. The surgical day is a busy day, and so we give a window where we're going to contact the patient rather than a precise time. So the patients aren't sat at the end of their phone disappointed that we haven't contacted them at the specific time. So yeah, a window rather than a precise time may be better. Next slide. Clearly, there are some things which are different, and they can be potentially harmful. You can't examine the patient, and we've had one patient referred to us who was diagnosed over the phone by his general practitioner as having a hydrocele. No ultrasound was performed, and in fact, the patient had a testicular tumor. So if there's any hint that you're missing something, you need to get the patient up to examine them. You don't get the body language responses that you get with a normal consultation. And you've got to be aware that you may be phoning the patient and they're actually in their workplace and they may not be at a convenient location to have a conversation with you. So make sure you check that the patient's in a location where they can speak freely about what may be embarrassing subjects. And if you have to give them a few minutes to get to a different location, make sure you do so and phone them back. Clearly, there are risks that it can lead to missing serious pathology. And as I said, it's a more linear conversation. I have a particular interest in historical sexual abuse presenting to a urology clinic. And it's very difficult to introduce the subject of previous sexual experiences when you're just speaking to someone on the phone for the first time. And although we think this is giving us equal access, it's possible that this is giving us further inequality of access to healthcare, with the more tech savvy having better access to healthcare, and it being less accessed and less accessible to the older, the poor, and those who have a lower health literacy. Next slide. So you have to define why you're phoning the patient. Is it a new patient or is it a follow-up? And if it's a follow-up consultation, one of the first things I do is, first of all, reassure the patient that the hospital is working. Patients have been frightened coming to hospital, and they're staying at home with symptoms that should be bringing them to hospital. So I make it clear that the hospital is working. If they do have acute symptoms, they should seek our advice. Define clearly if you're going to arrange a test, how you're going to arrange that test. And again, patients are used to receiving a piece of paper to book their next appointment. And when that's not happening, you have to define for them very clearly how you're going to arrange that test and how you're going to arrange that follow-up. Clarify that. And again, just reassure the patient that if they have symptoms, they must seek our care. If the patient needs examining, I can't emphasize enough, get them back to the hospital. Next slide. At the moment of the contact, you phone the patient, introduce yourself and describe what your role is in the hospital, and then say why you're calling, set the agenda for the meeting. Let the patient know whether this is how you're going to give them the information. Ask them if there's a relative in the room with them. That's something which is obvious when you're seeing a patient face to face, but they may be on a conference call. They may want other people to be listening into the conversation, and in that case, introduce yourself to all the people who are there listening. And ask the patient before you get going what their concerns are and what questions they have. Use simple, understandable language. You may not be able to use diagrams that you can for a normal consultation, so you may have to use language that is more basic than you would normally use for the consultation. And let the patient know that they can interrupt you at any point. If they need to interrupt you to clarify something, they must feel comfortable to interrupt you. They may feel uncomfortable doing that when they're speaking to someone from the hospital. And ask all the way through if they have any questions, and be clear about the follow-up plan. Next slide. And these are the things you mustn't do. I have written before in one of my blogs about the heart sync doctor, and that perspective was written for the face-to-face consultation, but it's just as important for the telephone consultation. Don't check your phone during the consultation. Don't do other things. Don't be answering emails. Don't be looking at Facebook and Twitter or WhatsApp, even TikTok. Don't look at the next patient's information. If someone knocks on your door during the consultation, that's obvious during a face-to-face consultation, but during a phone consultation, if your registrar knocks on the door, you want one of your colleagues or a nurse knocks on the door, tell the patient why you're not listening for a few moments. Don't cut the patient off. They can interrupt you, but don't interrupt them. And don't finish their sentences, and don't sound as though you're rushed. Patients are pretty wise, and they know when you're not listening, so make sure you are fully engaged with the conversation. Next slide. The Royal College has defined when not to use telecommunication. If the patient's uncomfortable with technology, if the patient's mental state isn't suitable, that you don't think they're going to be able to engage with a teleconference, when examination may be important, when there are safeguarding issues. And clearly only use video facility consultations if the IT facilities are good enough to support it. Next slide. So we knew this was coming. We knew that we were going to be heading this way. The GMC are very aware that the consultation has moved very frequently now, very often, to a teleconsultation. And in fact, I had the opportunity of interviewing Chris Massey, the Chief Executive of the GMC, for the Bulletin of the Royal College of Surgeons, and you'll be able to read that interview in a bulletin or two's time, I think in early 2021. And I can reassure you that the GMC is aware that the video and virtual consultation is a new form of interaction for a patient and doctor, and that they're aware that they may be missed diagnoses. And so I think the GMC is on our side when we're moving to video conferences. The bottom line is we've got patients who have fears, and we've got to engage with those fears. And if we don't engage with them as in a normal patient-doctor relationship, then no matter what technology we use, we won't be looking after them to the best of our ability. Thank you very much. I think that's the last slide.
Thank you, Jonathan, for a very lucid.
So, sorry, I forgot my last slide. Be realistic but not precise about the time. Set the expectations and the agenda, and ask the patient what's important for them. Focus on the patient. Be fully aware of your telecharisma. Don't do other things when you're off the screen. The patient knows it when you're not listening. Use lay language and easy language. Listen for cues about how the patient is receiving information, things we're so used to doing when we're seeing a patient face to face. You're going to have to get a feel for those when you're consulting on the telephone. And make sure that you finish with a clear plan and let the patients know when they're next going to be contacted, who's going to report the results of their scan to them, because they're in a new situation as well. They're used to seeing a consultant, being offered a piece of paper, and then having their next appointment booked. Reassure them that the system you have is robust, that you will contact them again with any results. Thanks very much.
Thank you, Jonathan, for the very lucid and transparent presentation. We may be able to take some questions if they are specifically meant for Mr. Glass. Jane,
So
do we have?
We've had a couple of questions through, but they aren't specifically related to Jonathan's presentation. So I don't know if you want to carry on, and then if people have got any queries that they inevitably think of as soon as you start speaking.
I'm easy.
You can take them at the end, or I can ask you a couple of the generic ones now if you're happy to have a few questions.
Yeah. Jonathan, do you have any figures as to how much numbers have changed in your own practice?
So my main interest is in kidney stone surgery, and we have a pretty quick turnover. And what I'm finding is actually the consultations are taking longer with my clinics over the telephone. Patients are so relieved to contact a doctor. I think the other very important thing about a practice like mine with a stone consultation is getting a feel for those patients who need urgent follow-up, those patients who you're suspicious have got a new stone, new symptoms, and those patients where follow-up can be deferred. I think one of the reasons for phoning patients is just to stratify the patients who you are following up, to decide who is sitting at home with pain but who's too scared to come and see us, and who's sitting at home relaxed because they're asymptomatic.
Thank you. I think, Jane, we can carry on with the next presentation. So I am going to take you to a geographically completely far away place from Aberdeen, and also anatomically also I work at the completely opposite end, being a neurosurgeon. And while Jonathan has given an overview with all various references and papers, I am going to concentrate and reinforce mainly what the guidance Royal College of Surgeons of England is providing. Next slide, please. So the virtual consultations are not new. Even in the pre-COVID area, especially in the place where I am working, and I've got some of the latest figures, because we are the second smallest neurosurgical unit in the entire UK, but we have the widest geographical area that we drain. Right up to the Northern Islands like Shetland, we are covering a wide geographical area, and therefore we used to have telephone consultations even before COVID era. So I don't think it is new. However, for surgeons, it may be less common as compared to some of my neurological colleagues who have regular video consultations. To give you just background, I have got figures from between 1st December to 29th of February this year, which is pre-COVID, and from 1st of March to 31st of May, the next 3 months, some of which was COVID era, we had 26 near me new consultations for the health board, as against 960 new near me consultations. That means a real increase by 3592%, 3,592% increase in near me virtual consultations. So that just gives an idea that how it has become relevant in COVID. And thankfully, the technology is helping. The managers are also providing necessary guidance, and Royal College has given a very good overview of what an ideal consultation could be and what are the do's and don'ts, some of which we have already touched base. In my opinion, even though COVID may disappear, the virtual consultations are going to stay, and therefore the need of the hour is to master the art of making the best use of available technology. Next slide, please. Now, of course, the prerequisites are patient's willingness, because we are all patient-centered. So if you remember that the center of our activity is patients, so their willingness and ability to communicate via telephone or video is paramount. The surgeon, as Jonathan has rightly elucidated, that examination is not always possible, and therefore when there is less need of physical examination or any special test required, the virtual consultations are good, and an agreed risk assessment should be taking place during the virtual consultation. Remember, a limited physical examination via video may be possible if the patient has equipment at home and is confident in using it. And I have some examples. For example, if I'm trying to judge the weakness of the foot, plantar flexion or dorsiflexion, I can make them walk tiptoes or on heels, which indirectly tells me whether they have weakness of plantar flexion or dorsiflexion of their foot. Next slide, please. Like we know, like in medicine, we should know the contraindication before the indications, or the side effects before the indication for a medicine, or complications before the surgery. We should know when not to use the virtual consultation, especially patients with high risk conditions which may need a physical examination, patients with unstable mental state, those who are cognitively having challenges, patients unable to use remote technology, or there are some safeguarding concerns. And therefore, this can be occasionally compensated by assistive technology or software development when patients with disability or sensory loss could be compensated. So there is a way around if there is a will. Next slide, please. What is the difference between a telephone consultation or a video consultation? We are more accustomed to a telephone consultation, and it is very commonly used even before COVID for a follow-up appointments. While the advantage of a video consultation is that it provides additional visual cues and is preferable for patients with comorbidities, patients who are anxious but may feel reassured when they see surgeon at the other end of the line, and patients who are hard of hearing. This is very important. We all are working in a world which is inclusive, and therefore specifically addressing the need of people who are hard of hearing. The lip reading gives them a very good real experience of a video consultation. So when we are talking about virtual consultation, we need to differentiate what is a phone consultation versus what is video consultation. Next slide, please. Now, having learned when to use these, we need to know how to use, and there are lots more technical considerations. If we go clockwise from the top, we need to have appropriate hardware equipment. We need to have a backup telephone number in case there are technical problems, and I will come back to this towards the end. We need high quality internet connections, and there are some specifications laid down. We can have hands-free handset to allow the surgeon to make notes, and accessibility of the platform remotely by staff. And we need to have a uniform software platform so that all across the board we are able to offer the same service. Next slide, please. There are two ticks. Yes, once we have this background, we need to train the staff, and then we also need to give patients enough information about what platform we are using and how best use can be made, and what support system is available on offer from the health service. Next, please. Now, we need to be conscious about the Data Processing Act, and therefore we need to take all possible steps to reduce the risk of patient confidentiality. It's the patient's responsibility to ensure that they have adequate anti-spyware and antivirus protections on their devices, because we are dealing with very sensitive information. The patient should understand and confirm that they are comfortable using their personal email accounts, which are open to breaches, to receive communication from the hospital. And patients should be informed that the consultation will not be digitally recorded without their prior consent. And likewise, they also need to let us know if they are trying to record something. Otherwise, it is a breach of confidentiality and contract. Next slide, please. Now, like a very good travel agent who tells us when we are planning for a travel 6 months in advance, looking for bargain, then they give us a list of things. They give us malaria prophylaxis. If you are going to an endemic area, then they tell us what to do 2 weeks in advance or 1 week in advance, making sure that the foreign currency is available, and the last day charger and all the camera. Similarly, the Royal College also told us what is the entire process, and there are 6 steps writing from in advance of consultation. So you need to choose which patients are suitable for audio consultation, which patients are suitable for video consultation. You need to be organized, as Jonathan has already mentioned. On the day of consultation, you need to have all the available information, the images, the records. At the beginning of consultation, we need to establish some ground rules. Then we proceed with the consultation. Before conclusion, we must make sure that there are questions answered. And after the consultation, thorough documentation should be carried out. We'll go this step by step through the next 2 slides, please. So next slide. So in the advance of consultation, we need to make sure that this particular patient is suitable for one of the 2 options I mentioned. The email should reach the patient for appropriate link to be established. And in the beginning, we used to have this challenge that patients used to wait a long time in a queue to link in. But I think that problem has been sorted with more experience and better technology. A test call can also be done, and we have a very nice outpatient clinic coordinators who sometimes interject and help us to iron out any challenges. In advance, arrangement should be made for special adjustments, especially if they're hard of hearing. As I mentioned, we could be preferring video consultation rather than just telephone consultation. On the day of consultation, we must make sure that we are in a very quiet and a private, well-lit room. We must make sure that the equipment and the technology used is efficient, and we must ensure the availability of a patient record, the images, and it is very helpful. In my experience, I have seen that showing the patient's images and using the models. For example, I have a real brain model here. I can't work without this, my colleagues say, naturally so. So using such props is very helpful for the patient to understand the pathology that we are dealing with or the planning of the operation that we are offering them. Coming back to the most important part, at the beginning of the consultation, we must confirm that they are able to hear and see us. And likewise, we also need to make sure that we can see and hear them both. We also need to make sure that they are comfortable in the place that they are, because sometimes people link in from their work. I have also seen recently a patient who was calling from his car. Of course, he was a front seat passenger. I made sure that he was not the driver, of course, but he was a front seat passenger, and I made sure that, are you happy to continue? Because of course the driver was listening to what we were talking about. We must confirm the patient's identity, their date of birth, their postal code, especially when we are doing it for the first time. We also need to take their consent that they are happy and comfortable with virtual consultation. And to be very honest, as Jonathan has rightly said, that the virtual world has crept into our life, but to be very honest, these consultations are as close to the real life experience as possible. And in a way, I'm going to go to the flip side, which is a positive side of this experience, that it has made a lot of difference to the patients and the surgeons like, which I will dwell later. Next slide, please. So during the consultation, there are various models people have used. In the medical school, I'm very keen teacher, so they are taught either an ICE model, like ideas, concerns, and expectations. We should establish what they are looking for. What is their goal? There, some people also use Cambridge Calgary protocol, but I generally find ICE is very easy. So at the beginning, I also establish the available time. For example, for a new consultation where I have got almost 30 minutes, I say we have about 20 to 25 minutes. That gives 5 minutes extra. Everybody likes bargain, so I am throwing 5 minutes extra on top of the 20-25 minutes I have already offered them. We need to give them some diagnosis and some concrete plan. A follow-up appointment is very important towards the conclusion. I'm not going through every single word and sentence of the slide because I want to leave some questions, but toward the conclusion, we must make sure that they have got what they wanted from the consultation. If there were any questions remain unanswered, we can go over those again. There are various ways to make sure that their understanding without insulting their background is established properly. After the consultation, we must document. It is very important to say that it was a telephone consultation or a video consultation, and that indirectly establishes the limitation of the consultation so that we are medically protected if the examination was not possible. We should send this documentation. It is a good practice, and we are slowly getting into that, to copy the document to the patients, because they will then be able to agree, and if they have any difference, then they can get back to us. I always leave my secretary's phone number to them in case they want to call back for any further clarification, and a follow-up plan for future appointments, either which can be telephone or virtual, or possible admission for an operation, is something I make sure happens before we end the consultation. Next slide, please. So now we are talking about the COVID era, and we must make sure that if they are having, they go on the waiting list for a procedure, then we need to find out whether they had any contact with COVID patient. Have they got any symptoms of COVID? You all know that loss of taste or smell or recent travel to a known hotspot. And as you know, more than the share market, currently the UK lockdown is changing so fast. Every morning and every evening there is a different message we get, and it is even interesting that it varies between England, Wales, Scotland, and Northern Ireland. I'm not going to go into the details of that. If there is a persistent temperature of more than 38 degrees or more than 5 days, persistent dry cough or shortness of breath, then we must make sure that they are properly screened and, if required, properly treated. Next slide, please. And the same thing holds true for their family members also if they have persistent symptoms. Next slide, please. All this information is available on this video link. Royal College of Surgeons of England has put in lots of efforts in making surgeons available this facility, and this video link will provide two examples. One, an example of an ideal virtual consultation, how to run that. Most of the points we have covered, but this will give you a further, what I would call a reinforcement learning. And there is also an example of a bad consultation. So basically what to do and what not to do. Next slide, please. I think I am coming to the end of my presentation, and I will be open to questions.
Thank
This
you.
link is, by the way, currently freely available, like the webinar tonight, but it is like gone. So be careful. A time will come when this will be only available to the surgeons, members and fellows. So it is currently available freely. Please make most of it. Thank you.
Thanks. We will try and make the resources available for as long into the pandemic as we're able to. So, but as Pragnesh has mentioned, these are available now for everybody, and you can find them on our website. We will also circulate the link during the email that follows up tonight's recording. So we'll send you a link to the recording, and we'll include the link to the VLE so that you can have a look around and explore those resources. We have started to get quite a few questions through now. So I'm going to start with a question regarding consent. So we've had a couple of questions about how you gain consent via a teleconference or a video conference, but we've had a very specific question regarding words that you can use to cover yourself for possible omissions that I assume of sort of symptoms or defects that will be missed because of it being a teleconference or a video consultation. So somebody is asking, the question is, can you recommend a form of words to cover yourself for the potential for possible omissions during virtual consultations?
Shall I answer that question, Jonathan?
Go on, Pragnesh.
Well, consent is my hobby horse, and I actually teach consent on a boot camp for last 2 to 3 years for the national neurosurgical trainees. So in my opinion, consent is one of the most important time I spend with patients and their families or carers. Coming to the answer for the question, in my opinion, it should be no different whether we are doing a virtual consent or a face-to-face consultation for consent. Americans are very good in medical legal medicine, better than us in some respect. And therefore, the words I have picked up from them are inclusive, but not limited to. So if you have included most of the complications known for the procedure, and at the end, inclusive, but not limited to, that means, and of course, from a legal point of view, the Montgomery ruling has changed significantly how we practice. So anything that may not be relevant or maybe trivial in surgeon's view, but if it is relevant to a patient, and you remember I'm quoting a patient with diabetes and a shoulder dystocia, this happened in Scotland, and therefore we are very all, and it is a game-changing concept. So try to include everything. For example, I can only quote the examples of neurosurgical procedures. So some of the good neurosurgeons have included vision loss in all the procedures in prone. So because there could be intraocular pressure increase, there could be more risk to retarded detachments or just by ocular pressure. So, but the answer to your question is inclusive but not limited to. Thank you. Jonathan,
Also,
you.
I think, Pragnesh, I think it should be stated in the letter that this has been a telephone or video consultation, that you haven't had access to examine the patient, and that you therefore there could be an oversight, and that you recognize that this consultation has been limited in that regard, and make a comment that in the era that we're working in, that you have proceeded with a decision without that examination being performed. And as I say, if you're in doubt whether that's a safe decision that you're taking, then you need to get the patient up and arrange to bring the patient to an environment which is safe in the hospital, organized with your administrators to make sure that you can find a space to examine the patient if necessary. But if you haven't examined them, that should be clear in the letter, that this has been with the best decision making that you can take in the context that you find yourself in.
Thank you. And another thing which also was mentioned in one of the slides is that because of the COVID, the less urgent procedures have very long waiting, more than average, and therefore their condition or their pathology might have changed towards worse. And therefore it is also important to include that in consent, that things might have changed, the benign tumor might have grown further, or the degenerative changes. I'm only using the examples from my own practice, that the degenerative changes from only 1 or 2 level in the spine might have progressed to another adjacent level, and therefore it is also important to add that we have a part 2 in consent, that any additional procedures deemed necessary at the time of operation would be performed. I hope that answered the question.
I think that covered it. It does also lead us nicely on to the next one, which is on a, I was going to say similar theme. It's not on consent, but it's leading on from this conversation. So we've had somebody asking about the value of teleconsultation, given that most or more than half will probably need to be followed up with a face-to-face consultation. Do either of you have any sort of thoughts or comments on that?
Yeah, I think it does have value, and I think one of the things is to get across to the patient, as I emphasise in my talk, that the hospital is open, that, that if patients need to come in, that they shouldn't be fearful of coming in, because we have patients not turning up. And I think part of the role of the follow-up consultation is just to reassure patients who are being followed up, we're following them up because we are concerned that they may develop some pathology. And it's an important way of sifting out those patients in a follow-up clinic who have what sounds like evolving pathology, and those patients who are follow-up clinic who sound as though their situation may be safe. So I think there is value in the follow-up consultation to triage patients in a follow-up setting as to who needs to be seen more urgently and whose further investigations can be deferred. And clearly we have to be selective at the moment in how many patients we can bring up to hospital. London's about to go down into a lockdown again, from what I hear. And in that context, we've got to be wary. Patients are very fearful about getting in public transport. But we, on the other hand, we don't want patients sitting at home with symptoms that are evolving. So I think there is value in the follow-up consultation, just to triage patients as to who needs to be seen.
Super. Brilliant. So moving on slightly, and I guess probably one of the reasons that lots and lots of people have joined us tonight. So how do you decide when to use a telephone consultation and when to use a video consultation? Either.
May I start
Okay.
first? Yeah. So when it is a follow-up appointment, it is very easy that telephone consultation could do as well. If it is a new patient, I feel it is better to do virtual consultation because it gives more real value added benefit. And therefore, to me, it is very easy to decide that new patients by and large gets virtual consultation as against follow-up more likely to have telephone consultation. Now, coming back to further about the new patients, if they are already investigated and I want to share the investigation results, for example, showing a scan, and the video link that I have provided is an example of a lady with a brain tumor who is not having an operation, but just to reassure the patient that this lump is benign and can be followed up with serial imaging, is a very good example that in new consultation, virtual was preferred option. On the other hand, if they are awaiting investigation, if a GP refers me a patient with a back pain and sciatica, where we are still planning to do a lumbar spine MRI scan, I think a telephonic consultation is a perfectly acceptable option, because then we can investigate and as a follow-up arrange a virtual consultation where I can share the result of the scan with the patient and plan further management. I hope that helps answer the question.
And I just, there's a paper also to suggest actually, Pragnesh, that surgeons as a rule go telephone and then examination, in other words, face to face, and the physicians love the video conference. I'm not sure if that's really the case, but that's what's been suggested in some data that I've been told of recently.
And I have also opted after these two options occasionally. I know it is perhaps not the remit of this presentation, but having gone through this process, there are some patients where we need to have a physical examination and a thorough neurological evaluation. We then choose to bring them for a face-to-face consultation. So these are are not exclusive to one another. But going back to the telephone consultation, at the height of COVID pandemic, when we were restricted, it was very reassuring to patients, and this is the feedback we have received. And in fact, one of my colleagues is looking at a wider picture, and I also know a trainee in Wales is looking at this, the patient satisfaction aspect of virtual consultations, and we can look at this. But most of my patients have felt very comfortable when we had a telephone consultation saying that how are you keeping, and has any change been there in your condition, or unfortunately we are not able to give you a definite time for your operation, and so on and so forth, or following an operation that they had due to an emergency, a telephone consultation was very reassuring. So most of them have felt that a telephone consultation has been a great help.
Of course, it also depends on your specialty, Pragnesh. I was amused at you saying about you watch your patients tiptoe or walk on heels. That may be fine for neurosurgery. It's not so good for urology to have their bits played on a video consultation.
Yes.
Yeah, I do think there's probably some differentials between the different specialties.
Exactly.
So again, leading us nicely on. So it's more, I guess it's a sort of an opinion or a, sort of in your experience sort of question. Do you feel like the introduction of teleconsultation has led to a greater reliance on imaging, and is there now increased demand from your, I always get this wrong, radiography clinics and your general imaging? Are you finding that you're having to ask for more scans and things in order to reduce your face-to-face clinics?
Yeah, I think that's a very interesting question, I must say. And I think it's so dependent on the experience of the person who is in the clinic. You know, we're fairly sophisticated clinicians. You know, I'm 30 years on into practice, and clearly we're able to make some decisions, get a feel for what the patient is telling us, which is clearly more difficult to do if you're more junior in your experience. And so I think with the juniors or the doctors in training and young consultants, clearly they've got to make sure we're not missing pathology, and that can be a tendency to call for imaging when you may otherwise not have done so. I don't think personally imaging should replace examination, and if you think you're going to need to examine a patient, do so. But yes, clearly on occasions it's easy just to bring a patient up for a scan. They can come into the hospital, have a scan, and go home again, and with encountering as few people as possible. And that can be organized pretty sharply, as long as I say, just make sure the patient understands how you're going to get that result to them, and you are going to follow up that scan. So I think it does depend on experience of the clinician. Pragnesh?
Yes, I completely agree. I also want to, I'm not sure, Jane, if there was any question, but you want to read any question? Because I want to bring another equation into this also discussion.
We have got some more questions, but if you've got something else that you'd like to cover just now, we've got a couple more coming through. So,
well, you know, we are all becoming environmental friendly, and one of the drives that Royal Colleges have currently is to reduce the carbon footprint, and these consultations have provided another dimension both for the patients and for the surgeons to avoid unnecessary travel, the traffic, the parking, child minding, or another arrangement that is required from work, absence, etc. So we can also look at the positive aspect of these, that I am in my own practice able to offer more readily consultations, either telephone or virtual, perhaps because we are not having as much operating to be able to do, only allowed to do what is most urgent. And but this telephone consultation, for example, we have an outreach clinic in Inverness which takes 2.5 hours to go, because we are not traveling, I have added 2.5 hours of my consultation. So that is obviously an advantage. And same way, because we drain the widest geographical area, patients from Shetland and Orkney or Inverness do not have to travel, and we can provide near enough service in a virtual consultation by telephone. So this is the positive side, and environmental friendly as well.
Yeah, Ragnish, I hate to think how far you go in half an hour of travel compared to how far I go in half an hour of travel in terms of miles covered in London. But I think that the college has recently set up a sustainability group, and it's not only looking at sustainability issues within the building of the college, but also how surgeons can impact on the environment by looking at less wastage, avoiding throwing things away unnecessarily, and certainly the virtual consultation may have a big impact on that in the future.
Yeah, I do. I think, and I would tend to agree. I think it's especially when you're talking about the miles that Pragnesh is looking to cover. So there is the also, and the from a purely the NHS is benefiting from 2.5 hours more of his expertise, which is always a good thing. So we've got a couple on some slightly different themes now. So we've had a few people asking about the medico-legal implications, which brings us a little bit back to consent, including are we likely, in your opinions, to see changes to your defence premiums and this sort of issues is probably the wrong word, but sort of implications of the defence unions and the potential for being sort of sued due to misdiagnosis or people feeling like they're not getting the same service as they once did?
Yeah. Well, again, just to reinforce, Victoria Pena, one of the other members of council, and I think the first registrar to be voted as a member of council, and I had the opportunity of interviewing Charlie Massey in this regard when we interviewed him for the GMC for the bulletin, and he was fairly clear that the GMC understands that the world is changing and that he has a responsibility to make sure that the GMC isn't looking to criticize doctors. I think there's a huge move with the GMC to make sure that they're not bringing doctors in front of the GMC for a single issue. So I think that's something which I found very reassuring when I spoke to Charlie Massey, that they're much more reluctant to bring doctors to the GMC for a single clinical issue. And I think they're taking this on board with respect to the virtual consult as well, recognizing that we're in a situation which may produce some uncertainty, could produce some errors, but not looking to apportion blame. And I must say, I found our conversation with Charlie Massey quite reassuring in that regard. Moving on to the video consultation or the telephone consultation. Pragnesh, any thoughts?
No, I think there will be some ramifications of this distance consultation process, but I believe this will become a part of our life, and like as we are evolving and becoming modern, whatever I'm allowed to say, or more legal minded. If you go back in time, as you said, you have been practicing for 30 years, I'm sure you would have seen increase in medical legal issues as compared to when you started. Even the COVID had no effect on this. So I am sure the COVID or this virtual consultants will add a fuel to the fire.
And actually, we're looking forward to the era, the post-COVID era, where it's, as I said, part of that mixed economy of consulting, where we choose whether we bring a patient for the face-to-face consultation, or we or the patient chooses which they would prefer. At the moment, it's being forced upon us. But it'll be much more exciting to run a clinic when patients have made the choice as to which they opt for, whether a virtual clinic, a telephone clinic, or a face-to-face consultation, and when it's not a mandated event as it is at the moment.
So interestingly, that brings us on. One of our questions was regarding how the pandemic has been affecting those willing to attend clinics at hospitals. And from what you've been saying, I feel like, for different reasons, I feel like there's been a sort of reluctance on some part of some patients to put themselves at risk. Is that a fair thing to say?
I think you can't underestimate how scared some of the patients, particularly the vulnerable and the elderly, are feeling because of the information coming from government and the feel that they've had from reading the papers. And so, as I say, that's why I'm really emphasize when I make my phone calls that the hospital is a safe environment, and that they should feel that they can come to the hospital safely, have a consultation with a doctor who will be appropriately prepared with a mask, etc., to see them in a reassuring way, and hopefully in a way that they feel reassured, and that they shouldn't be sitting at home, sitting on pathology which may be advancing. They should make sure they don't feel fearful, and they should come and see us.
Super. I think we are heading towards careering towards 7 o'clock, depending on which clock I look at. So I've got a couple more if we're okay for time, and then I think we will have to call it a night. I do think there's something quite ironic or joyful about the fact that we're doing a virtual consultations webinar virtually and not in our relevant offices. I was commenting earlier that we used to get panelists into the building, so there is something quite just about us being all online in our respective homes and workplaces. So I think there's somebody has suggested that maybe the college should be looking at providing a simulation training for virtual consultations, as this is looking like a part of all of our futures. Do either of you have any comments on that?
I think the attendance in a clinic by our junior doctors, we're obsessed about teaching surgical technique, and less obsessed about teaching the interaction with the patient. And certainly it's been a problem in our own department. We don't get doctors in training to come in often enough to come and sit in a consultation with us. And I think that's a very good idea. I think there are new ways of working, and I think it'd be very good to. It lends itself to online training, and that's something the college could think about preparing.
We have gone actually a stage ahead. We have started in the medical school. The senior year students, year 4 and year 5, are allowed to sit with us in the virtual consultation with the patient's permission, because tomorrow they will be conducting most of the clinics virtually, in my opinion. And therefore, we have already taken a step ahead and started educating medical students, the future surgeons. Thank you.
Brilliant. I think that does bring us to 7 o'clock. So we've had a few people coming in thanking us and giving us some really great feedback for tonight. So thank you for supporting this. There's a couple of outstanding questions which we'll follow up post-event that were just a bit more complicated. But thank you to all our delegates, and I hope you all have a very pleasant evening.
Thank you very much.
Thank you, Jonathan. Thank you, Jane.
Thanks.
And thank you all the audience.
Thanks very much.
Thanks. Good night.